Hello, good evening, everyone. Can you see my slide? Um, can everybody see my slide? Just give me a thumbs up
Yes,
or yeah, cool. Um, Great. And is it the slide for neurological bite paces that you're saying?
that's right.
Correct. Okay, yeah. So we can roll now. So that's my name. Today we'll be talking about neurology examination, which is sort of a sequel to the previous lecture module that we had a couple of weeks ago on just neuroanatomy, localization, and examination. I think we dwelt very comprehensively on that. So the outline today will be just talking about the NeuroPaces format, which is, what aspect of neurology or what's the shape of the neurology in the PACES exam. I will do a little bit of a recap of lecture one, and then we dwell into lesion localization, and then talk about differential diagnosis in neurology, investigations in neurology, and then we'll give an example of presentation models, because I believe that's one of the areas where how do you present, your findings in that short space of, time. And then we do some cases. So we will need volunteers. We will need as many volunteers as we can get, just a good number of them, because if we have 10 volunteers, we'll do 10 cases. So if we have only two volunteers, we do two cases. So yeah, I'll oblige everyone to arms up to volunteer, and then we'll do some slideshow to finish. At the end of this talk, I expect that we should be able to perform a timely neurology exam, and also we should be able to identify neurologic signs and cool. I can see. Yeah. Okay. Yeah. Thanks, Jelani. Just let me know who has volunteered. Um. Yeah. And then present neurologic findings, outline differential diagnosis, and then profile relevant investigations, and of course, institute relevant management plan within the time frame allowed. So without further ado, um. Yeah. Cool. So this basically is I'm sure you're familiar with this diagram, new model, PACES 2023 carousel. So the neurology station is in station three and is embedded with cardiovascular examination. You need 10 minutes of examination, identifying signs, presenting your case, offering a comprehensive management plan, and then you move in that order. Okay, so at any point, you can enter the neurology station from either station two, yeah, usually from station two. But I'm also aware that you can also have neurology-based cases in the long case, in clinical consultation. So we'll talk about that as well today. And this is the usual mark sheet. So usually you're assessed on physical examination. So they are going to assess your examination skills. And then also you should be able to identify physical signs. Many candidates, I tell you, I mean, even as a neurology, someone in neurology, I know I had some issues here earlier on in one of the exams. So yeah, so identifying signs is a big deal. And again, you don't see what you're not looking for. So if you don't know what you're looking for, even if it's there, you're never going to see it. So we hopefully with this course we should be able to, just cover a number of areas, familiar areas that we at least high yield areas that will help us to identify clinical signs. And then of course differential diagnosis, clinical judgment, and managing patient welfare. I'm not going to dwell on managing patient welfare. If you're in the UK, you don't have any problem with that. But if you're outside of the UK, managing patient welfare is very key. An examiner may veto you just because you didn't manage patient welfare. How does that happen in a physical examination station? If you're going to examine a patient and potentially the patient is going to have pain, let's say you want to examine the lower limb and you didn't ask if the patient have got pain anywhere, and you just you delve into it and the patient kind of scream, "Oh, okay," and so that's one minus. You're going to watch for your reaction. If you kind of just ignore and just keep going and not mind what the patient is grimacing or winking in pain, then you're going to fail. They're probably going to veto you because you didn't care. So even if you got all the signs, you're not going to pass. Okay. But if that happens, I remember back home when I was doing my examination, we have this kind of exam as well, where it's not called PACES, but we call it part one, part two. But in my country, my in the respiratory station, my patient winked in pain, and I stopped the examination immediately, and they're like, "Do you want me to continue?" Now, don't get me wrong, I didn't know how that came to my head. I was ready to stop the exam. I say, you don't have to let me continue. I can stop if you want to stop. And the guy smiled at me and said, no, no worries, continue. And I got a very high mark there. So it's not really about what happens, but how you deal with it. So, just a little bit of a recap. So, the nervous system, okay, is classified as follows: central and peripheral. Okay, keep this picture in mind. Remember, the peripheral nervous system consists of the somatic and the autonomic nervous system. So everything else almost apart from the brain and spine and the retina of the eye is in the peripheral nervous system. And so this is summary of how you should do a neurological examination. So inspection is key. So you need to inspect the patient and the surroundings. Okay. So you can start either way. You can start from the surroundings and then you move towards the patient, or you start with the patient and then look at the surroundings. That should happen within seconds. And then you, of course, if you're examining, if it's a cranial examination, or if you have to examine this patient neurologically, because that's a trend that is happening now. Yeah, I've had many candidates say they didn't ask them to do upper or lower limb. They just asked them examine this patient neurologically. Okay, and so of course you need to go from top to bottom, and expectedly cranial nerve examination will come into focus there as a starting point. And then, but if you ask to examine the upper limb, for example, my recommendation is that always start with a task. So if you examine the upper limb, for example, an example of a task would be, oh, can you just knot your tie for me? Or can you unbutton your shirt or your dress? Or if she's a lady, can you just pretend that you're wearing your wristwatch? Okay, and that kind of thing. And that will tell you a lot about manual dexterity, whether patient, fine movement. If the patient is tremulous, you may see the patient having tremor right away. Okay, so start with a task. If it's a lower limb examination, gait is a task there. Okay, look nowhere, gait. And in the last lecture in the module one, I did mention that by their gait, we shall know them. Okay, actually, you can make almost any neurological examination by observing gait. And then, of course, you move on to tone, power, reflexes, coordinations, sensation in that order. Now, there are 5 modalities of sensation. Of course, you talk about the pinprick, soft touch, um, joint position sense, vibration sense, and temperature. Now, we do not always test temperature in the exam, and most of us think it is impossible. Actually, it's so straightforward and easy. If your tuning fork, okay, your 128 hertz tuning fork is usually very cold because it's made of aluminum or steel. So it's cold, okay? By default, it's cold. So you can actually test temperature, okay? Just asking the patient how does it feel. Of course, you test for yourself, make sure you don't have any temperature impairment. So you know it's cold, and then you ask the patient to feel in an area of his body where you think he should be able to feel the temperature. So he's going to tell you it's cold. You can start with the face or the foot is cold, and then you can now check any other area in the legs or arms just to see. If a patient is telling you, oh, this is warm, when you know actually it's cold, then you know there's temperature impairment there. So yeah, you can test temperature. And just to say, we talk about sensory dermatomes, but let me just make a comment around. So there are 5 modalities. Now you've got 10 minutes to examine and present and finish that station. So practically, some candidate will struggle with doing all 5 modalities or even the 4 if you're not doing temperature. Okay. Now you need to understand what these modalities represent. Okay. And I'll tell you right away. Soft touch and, excuse me, vibration sense and joint position sense, they test the same anatomy. They test the posterior column. So doing the 3 of them is almost like a waste of time in that exam situation. Soft touch, joint position sense, vibration sense, you're testing the posterior column, okay? Whereas temperature, pinprick, you're testing the spinal thalamic tract, which is different, it's a different anatomical area. So a smart candidate would rather test one of either quickly. And if you got time, you can just add an extra. So my approach is pinprick. I've tested spinothalamic touch, tract, and then one of vibration or joint position signs, and you're done. Usually you have a few seconds left. So you can, so if you do pinprick, vibration, or if you're very fast with joint position, you do joint position and then do vibration. Yeah, you can, that's sufficient. Of course, your presentation, you can always say you would have, if you had time, you want to complete the other ones, okay? Is that all right so far? Please feel free to stop me. Sorry, Jelena, if let me know if there's any thing you need to draw my attention to, questions on the chat. Yeah. So, oh, I was going to talk about the sensory dermatome. Yeah. So again, I thought I should bring this up. Now, many candidates, okay, when they're testing sensations, you see them wasting so much time just testing sensation. For example, they're going to touch the shoulders, either shoulder here, here, here. And you see them touching like maybe 6 places on either arms or upper limb. That's a waste of time because you don't have time in the exam. So testings, whether it's temperature, pinprick, soft touch, is based on the dermatomes, the dermatoma distribution of the body. Okay. So you need to go back to your anatomy and have a look again on what the sensory dermatomes are there in the upper and the lower limb. So you can see that C5, axillary nerve, sorry, this is not listed in this C5 though, but of course axillary nerve is C5, and then that's C7 on the lateral side. Okay, sorry, C5 on the lateral side. Yep, lateral side, and C6 and 7. Okay, and then of course you got 8 and T1 down. Okay, so if I am testing in the exam, I'll test the shoulders or deltoid area. That's C5H. Okay, and I can literally move to the middle finger. That's C7. So I don't need to actually test the forearm again because C5 has been taken care of. And so if you do C5, C6, 7, 8, T1, that's so at least 3 or 4 areas is fine in the upper limb, okay, rather than do 6 or 8 areas, okay? So C5, 6 from the lateral forearm into the thumb, then that's 6, 6 in the middle finger, so C7 in the middle finger, and C8 in the little finger up to the medial forearm, T1 just below the axilla. Okay, in the upper limb, if you put your hands in your pocket for the males here, if you put your hand in your pocket, that's L1. Okay, anteriorly, that's L1 already. Now L3 is around the knee. So between L1 and L2, L1 and L3 is L2. Okay, so you don't have to think about that. So in the lower, and then the other thing you need to know is that the medial part of the leg is L4, okay, and L5 is the lateral part, and most of the 95% of the anterior part of the foot, which is the dorsum, is L5. Just a little bit around the small toe, little toe is S1. So if you're testing, dorsal surface, that's, you're testing for L5 already. And then the little toe, that's S1. And then you go to the media, that's L4. And the knee here, that's, so you're done with sensory testing. So you must know what you're looking for. Luckily, neurologists are not assigned to neurology station in the basic exam. So you won't get punished, but just be aware, just to save your own time. And so, still on the recap, so essentially in neurology, we're trying to identify or distinguish upper versus lower motor neurons. And these are really basic, but they are the building blocks of neurology examination, neuron, lesion localization, etc. Okay, as you know, for upper motor neuron lesion, site of the lesion usually in the hemisphere, cerebellum, brainstem, spinal cord. And the lower motor neuron starts from the arterial horn cells, nerve root, peripheral nerves, and neuromuscular junction. Okay. And the sort of weakness you have in upper motor neuron lesion is described as pyramidal weakness. So what's pyramidal weakness? They can either be quadriplegia, hemiplegia, diplegia, or paraplegia. But beyond that, in the upper limb, pyramidal weakness means the extensor is weaker, it's more affected than the flexor. And in the lower limb, the reverse is the case. So the flexor is more Flexors are more affected than extensors in the lower limb. Okay, again, I take that again. Pyramidal weakness in the upper limb, extensors are more affected than flexors, and in the lower limb, the reverse is the case. Flexors are more affected. Okay, but lower motor neuron weakness are usually described as distal or proximal. So proximal essentially means they affect more of the muscles, okay? And distal, of course, suggests that it's a neuropathy. If it is a non-pyramidal type of weakness, then it's obviously it's a lower motor neuron weakness, and it could be distal or proximal. Increased reflexes are seen with and tone is seen with upper motor, and decreased reflexes and tone is seen with lower motor. And fasciculations are usually absent in upper motor and present in lower motor. Um, Abdominal reflex, we don't commonly do it. I mean, probably not be allowed to do it in the exam situation, but just to say that it's absent in upper motor and present in lower motor neuron. So this is an example of the motor unit, okay? So we've moved on to lesion localization. So how do we localize a lesion? And this is the million-dollar question that every neurologist, try to answer each time you get a referral. Okay, so what is the lesion and where is the lesion? So most of the time we get the question, oh, please help us see this patient with left leg weakness. So that's the lesion. That's his lesion. So our task is to kind of characterize that lesion and also determine where that lesion or where the pathology could be coming from. And that's it's not magic. So what we normally do, is based on whether it's upper or lower motor neuron lesion. And if you look at this motor unit, um, as much as possible, let me just try my best. Let's say this patient. So let's look at the structure. This diagram was present in the last lecture, but for the sake of those who weren't present in the last lecture, I'll just go over it again. So that's the brain there, okay, right and left side. And this is the hand, okay? So you see, let's start with the sensory. Let's say this guy put his hand on warm water and got burnt, right? Okay, so that sensation is going to travel down the nerve endings, okay, on the green, well, hope that's the green color, green, and then get into the spinal thalamic tract, okay, ascending tract, and ramifies around the brainstem, the axons and the area, moving to the brain through the brainstem and go to the commissural fibers. Now, that is sensation. So you could say, oh, this guy has got impairment. Let's say he's no longer able to feel in the arms, for example, because he's, sort of damaged some nerves by putting his hands in hot water. So you could say, okay, there's some sensory impairment in that area. And if you want to, go via the dermatomes, you could see that this area is around, you could say C6, C5, C6 area, okay, on sensory impairment alone. So most sensory impairment are likely to be lower motor, or however, that's if they are in a particular pattern or what they call length-dependent distribution, okay, which is we're dealing with in this case because there was a damage and injury here in the tip of the finger, and that area of the nerve is injured, and so it's a length-dependent type. And that's why it's lower motor neuron. Upper motor neuron sensory impairments usually occur in patchy distribution. So a patch of a nerve could be injured or inflamed, and patient have sensory impairment along those distribution. All right. So that's how sensory happens. Now for motor, so let's say this arm is weak. So that's arm weakness. So your task is to determine, is this weakness upper or lower motor neuron? And how do you do that? So first things first, inspect. If there's evidence of muscle wasting, that's already telling you that you're probably dealing with a lower motor neuron because that's where you find muscle wasting. However, we do know that in upper motor neuron weakness, you can also have wasting, especially if it is chronic. Okay, but just for the sake of argument, we say, okay, weakness is found in lower motor neuron. Okay, so that hand is weak and you've got some muscle wasting, I should say. So there's some wasting there. That's already giving you an indication that you're dealing with a lower motor. And then you check the reflexes or the tone. The tone is hypotonic. Okay. And remember to go TPR in that order. So hypotonia. Again, that buttresses your thoughts that this could be lower motor. And then of course you check the reflexes. And again, you've got decreased reflexes. So this is likely going to be a lower motor neuron weakness. Okay, so the presence of hypotonia, hyporeflexia, in the presence of a weak limb you're more likely dealing with a lower motor neuron weakness, either proximal or distal. Okay. However, the opposite is true. If there's increased reflex, increased tone, in that case, you're localizing the lesion to either the spinal cord or the brain. Okay. Now, if there is weakness and you've got upper motor neuron lesion signs all through, how might you know whether this weakness is from the spinal cord or the brain? Can someone just say what else he will look out for to sort of localize to the brain rather than the spinal cord? I like my we like this the sessions, BitePACES sessions to be interactive. So we're all learning from each other. Good. So someone said cranial nerve, yeah, cranial nerve, yeah. So you must qualify that a little bit. So there's upper motor neuron type, cranial nerve paralysis. Then actually in the contiguous area anatomically. So what I mean by that is that so if it's the left side, the left arm weakness, you expect the left facial weakness to be on the left face as well, and with an upper motor neuron type and upper pairing. And so yeah, so you could say, okay, this weakness, it seems like it's coming from the upper motor neuron, the brain. So I'm going to do a brain scan. Unlike if there is no cranial nerve involvement, no upper mental function involvement, for example, slurring of speech dysarthria or dysphasia, then you limit your scanning to at least cervical spine downwards or cervical thoracic spine. Yeah, so that's how we localize lesion. And as you see, the reason we localize lesion in neurology is to help out not just the diagnosis, to help us with our investigations. Because assuming we don't have all the money in the world and we don't have the resources in the world, so you need to be bespoke. You need to target and tailor your investigations to where you're going to have yield. It's of no use a patient coming in with headache and without any upper motor neuron signs, just scanning. Okay, there's risk of radiation and all that. Okay, or you're localizing, you have a patient having left hand weakness, lower motor neuron type, and then you're doing an MRI scan. It doesn't make neurologic sense. Okay, it doesn't make neurologic sense to do that. So yeah, so localizing lesion helps us not just to for etiologic reasons, it also helps us with diagnostic investigations and of course management approach. Yeah, and that's what I've just said. So upper motor versus lower motor neuron weakness, central versus peripheral. Good. So let's progress. So we move on to differential. So how do you tease out differential diagnosis in neurology? I, at the risk of, you know, argument, I think neurology differential diagnosis are the easiest. Okay, you may not agree with me, but let's go on the ride and see. Now, there is this acronym that has stood the test of time. Vitamin D or Vindicate. Okay, I should kind of prefer the Vindicate. So if you have a neurologic lesion, all you need to do is to vindicate it. Okay, so what does that mean? So V stands for vascular, I stands for infections or inflammatory, N is for neoplastic, D is for degenerative, I for idiopathic or iatrogenic and intoxication, C is for congenital, A is for autoimmune or allergic, and T is for trauma, toxin, alcohol falls in that category, and E is for endocrine or metabolic. Okay, or if you prefer, you can do vitamin D, and that's what it shows them. There's another short structured one, but you can ignore that. So never mind. So why do I say that most neurologic differential diagnoses are going to either be of vascular origins? So vascular origins and traumatic origins are usually acute. Okay, so if you have to look at listen to the question. Sudden onset, whatever that means is sudden. Okay, so you can't be thinking of, for example, a muscular dystrophy in a patient with sudden muscle weakness and wasting. Sudden. Okay, you shouldn't be thinking of muscular dystrophy or any of those chronic condition. So sudden suggests it's either vascular, stroke, cerebrospinal thrombosis, for example, or trauma. Okay. Whereas if it is subacute, so subacute usually mean happening within a few days, maybe 24, 48 hours up to 72, 96 hours thereabout. Happening, roughly quickly, but within a short space of time. You find that in inflammatory condition, infection, and it makes plausible sense, isn't it? Because if for you to have an infection, you'd have a microbe invading tissue and triggering inflammatory cytokine response, and of course, inflammatory response, rubor, dolor, and all that. So it takes a while, okay, for you. So it makes sense that it takes hours, days for it to be subacute, and then chronic, of course, that takes from weeks, months, and years. So these are very important. In the same vein, age and sex also plays out in the differential diagnosis of patient. For example, a patient with migraine and sudden loss of vision, a 20-year-old female, headache, abrupt onset of headache, loss of vision or visual disturbances, okay, versus a 70-year-old lady who's coming with headache and visual disturbances. You'll be thinking of the same diagnosis, okay? For the 70-year-old, probably thinking of GCA, and for the younger lady, probably thinking of a migraine. Yeah, so that's how we generate the hypothesis and differential diagnosis in neurology. And in terms of investigation, and this is my best part, because there are just four investigations basically that we do in the whole of neurology. For generally speaking, okay, of course, there are new digital and innovative stuff that are done in special cases, but there are actually four of them. But I've tried to put this in a structure for us to understand. So the first investigation is bedside. So that's the first B, bedside. And that within that we have fundoscopy. That's very important. They take that very importantly in the exams. Checking BMI, anthropometric measurement, charts, um, aids, walking aids around, okay, footwears, cognitive screen, for example, ACE, that's the Adam Brooks, and then of course checking medicines. Now you may think, oh, how is this important? You may just be surprised that the only thing you might find, I haven't seen that yet, but it's not impossible. They can actually put a CT scan result, okay, on the table by the bedside examination. So if you didn't see it, if you say, oh, this patient got a CT scan showing hematoma on the left side, just by inspecting the bedside, that's already you know what you're going to find on the examination. Or you saw steroids as the medicine or insulin. You know you're probably going to be dealing with diabetic peripheral neuropathy. So take your bedside examination seriously. Then the other B is bloods. Okay, so there are routine bloods, the full blood count, using these liver function test, ESR, CRP, those are routine. But in neurology, we have other specialized bloods. Okay, you don't have to say them that way. Some examiners may not know what neuropathic bloods are, but if you want to be specific, just a B12 folate, myeloma screens, if you're dealing with neuropathic bloods and so on and so forth. Vasculitic or autoimmune or inflammatory screens, of course, that include the autoantibodies, anti-nuclear antibody, and all that. Quaporin 4 for neuromyelitis disorders, and of course, oligoclonal bands, etc. for multiple sclerosis, for example. Paraneoplastic screens, blood screens, of course, we are thinking of a chronic condition, probably cancerous. Yeah, you can say that. So routine and specialized bloods, that's what I would say. Then lobar puncture, which of course is how you examine CSF. A lot of information can be gotten from that routine and protein cells, blood, xanthochromia for subarachnoid hemorrhage, etc. And then, of course, imaging. So, initial imaging, depending on what you're suspecting, if you think, oh, this patient may have a vascular event, hemorrhage, CT scan would be your first choice. But if it's something inflammatory, MRI will be your first choice. Other type of imaging include angiogram, where you look at the arterial circulation, and venogram, where you look at the venous circulation. And you could have this happening with or without contrast. There are other forms of imaging. You may not need to know about that, but just know that they exist. Functional MRI, which basically just check blood flow. And some of them have quantitative materials that you can use to measure in concentration of stuff. And these are usually used for diagnosing muscle disorders, for example, dystonia muscular dystrophy. And nuclear studies, I'm sure you're familiar with that scan for Parkinsonism, and all there are others as well, FDG, PET, and SPECT. These are all nuclear studies. Neurophysiology, which fondly called electrics. So nerve conduction studies, electromyography, and electroencephalography and EEG for investigating seizures. So yeah, and then neurogenetics for chronic condition. Let's say you've got a patient of Charcot-Marie-Tooth disease, you want to mention neurogenetics, and these have different forms. You don't need to know all this. There are new digital tools for imaging peripheral nervous system, surface EMG for looking at the trisomas of bladders, and so on and so forth. But you don't need to know all that. But just to mention, so four investigations in neurology, or maybe five: bedside blood, lobar puncture, brain scans, neurophysiology, plus or minus neurogenetics. Now, how do you do a presentation in neurology? You've examined this patient, you found signs, and you want to start talking to the examiner. So my recommendation is one of two approaches. Okay. The first approach is what in other systems, respiratory and cardiovascular, for example, they say talk about the diagnosis first. Let's say this patient have got aortic stenosis as evidenced by ejection systolic murmur, blah blah blah. Okay, but in neurology, I think it's sort of similar, but if you want to put it in a very nice way in neurology, you say you're talking about pathological summary. And I'll tell you what I mean by that. So if I put, so let me go back to cardiology again. So, okay, especially I've got heart failure. Okay. Now, heart failure in itself is not a diagnosis, isn't it? Heart failure is, a pathologic summary if you really want to think about it. So that's what the patient have got. But there's something causing the heart failure, either aortic stenosis, causing the left ventricular dysfunction and, causing heart failure. Now, if you come back to neurology, your pathologic summary could just be, oh, this patient have got upper motor neuron type weakness. Okay, so there's upper motor neuron type leg weakness or arm weakness. That's your pathologic summary. Yes, you've examined tone, power, reflexes, and everything, and you've come up with the summary that this is an upper motor neuron type weakness. Okay, that's one approach. So you could say this patient have got upper motor neuron leg weakness, as evidenced by increased tone, increased reflexes, power, MRC power grade 3, sensation is intact, and so on and so forth. Okay, to break it down that way. And then, of course, we will go to the differentials. Or you could use the other approach, is what I call the anatomical listings, okay? Which just basically starting from the other side. So you're presenting, so, okay, an examination of this patient, and usually you go from the order that you examine. So patient have got on inspection, patient have got evidence of muscle wasting in the quadricep muscle and the calf. Okay, tone is reduced, power is 3/5, reflexes are diminished, plantar responses are flexor. Okay, so you could go that way. Okay, putting all together, I think this patient have got lower motor neuron weakness. Now you could see that approach is a bit longer. Okay, it's a bit longer because time is of essence in the exam, isn't it? So choose whatever works for you. I what I'm not in, I don't I'm not in favor of any particular one. Depends on what's before you. If you feel pathological summary will be a good start for you, go for it. Upper motor, lower motor neuron weakness, go for it. But if not, if you're not comfortable, you can just go for the anatomical listings, which you just kind of the brick wall, you build from the brick wall rather than from the wall to the bricks. You know what I mean? Again, the other thing you need to be aware of in presentation is always start with your positives. I can't count how many times examiners frown when candidates talk about the negative things first. Okay, when they mention what they haven't found, this person have got there's no this, there's no that. So what is it? Nobody have got. They really frown. I've observed, have some observations myself, and I've seen many examiner frowns when the hello. Oh, what happened? Did I lose something? Can you see my slide?
Yes, we can, Sonny.
Oh, I've mistakenly pressed something. Just give me a
What's wrong?
second. No, I think it's just from my side. Oh, yeah, good. Yeah, sorry, apologies. Yeah, are you following me so far? You know, this feels like you just talking into, yeah, but thanks, Jelani, for voicing out something. Yeah, so I'll just continue. So start with the positives, and you can also go from what I call centripetal or centrifugal approach, which means either you talk about the patient before you first, and then spread out into the surroundings, or you start from the surroundings, okay, and then zone in into the patient. So whichever approach. So the centripetal approach is the patient and then the surrounding, and the centrifugal is from out the surroundings into the patient. So whichever approach, subconsciously, mental, just have that mental structure when you're talking about these things. Examiners like structures, okay? And then there's this other aspect, okay? Now, there are times when you can't complete the examination either because of time or because you don't have sufficient mastery. Don't worry. Yeah, let's say you did sensory examination, you did just pinprick and vibrational sense, or just say just pinprick. You could, you don't have to fluster about it. Just at the point of presentation, say to complete my examination, I would have loved to complete the sensory, blah blah blah, and that's fine. Okay. So, and then it's also useful to talk about further history and other neurological examination that you have loved to do, which I've just said. Okay. So, yeah, your presentation is part of your examination in that sense. And then in presenting differential diagnosis, of course, like I said, remember vindicate. Um, Most of examinations cases, there's no history there, so you're never going to know whether it's sudden or subacute, but you can also know based off on the neurological examination that you're finding. For example, if a patient have got a walking stick, I've got muscle wasting, I've got pace cavus, you know that this is not an acute thing, and this probably is at best a subacute thing, or most likely a chronic situation that you're dealing with. Okay. So we'll talk about that when we're doing the presentation, give an example presentation later on. You can actually also mention in giving a differential diagnosis. So if, for example, you've got a patient with lower motor neuron weakness, okay, or let's say it's got lower motor neuron weakness, and you presented that case, you could say, if this and you want to give differentials here, if this happening at the acute setting, I'll be thinking of GBS, for example, okay, GBS, and maybe if it's a unilateral weakness, you want to talk about stroke in the acute setting, because in stroke and in the acute setting, you can have what they call neuronal shock, which will give you lower motor neuron signs rather than upper motor. But don't mention that first. But just saying, so you can actually in your presentation, you can demonstrate to the examiner that you are well aware of the acuteness or subacuteness or chronicity of this condition. So because in that space of time you don't know the whole detail. So you could say if this happened in the acute setting, I'll be thinking of this is that. Well, if it happened more of a chronic or long setting, these are my differential diagnoses. So you could say that and aim for at least two or three differentials. Yeah, two, three. Three is a good number. Just aim for three differentials, okay? And then investigations, like we said before, bedside bloods, CSF, imaging, neurophysiology. It's not more than that, usually in neurology. Yeah, you never go wrong with that. But please don't mention nerve conduction studies where you think you have upper motor neuron signs. So if you're dealing with a stroke, multiple sclerosis, do not mention nerve conduction studies because it's not relevant. They're not going to take that lightly. And management, now everyone have got his own approach, but for neurology, remember MDT. Even if it's just a fraction of a second left, and you mention management will be multimodal led, that's a pass. You are fine. You're okay. You're good. Okay, because most neurology, hardly any neurological diagnosis or condition is managed without an MDT. Okay, but traditionally you could use the approach of conservative versus specific, medical or surgical, non-pharmacological or pharmacological, as the case may be. So next we'll talk about an example presentation. And for volunteers, please Jalini, if you be kind enough to just kind of put people on queue, please volunteer. As many as can volunteer today, tonight, volunteer. Okay. If we have only two volunteers, we do two cases. I have enough cases to go around. Okay. But if you have only two, we stop there and that would be so unfortunate. Okay. So I will leave that leave the queue for Jelani to arrange. And so because after this slide, we'll go into um the cases right away. Okay, so this is an
Perfect.
example presentation that I just developed. Okay, it's a prototype, but of course you can modify in your own way. So this is a patient that I've examined who's got I examined the lower limb examination, did the lower limb examination, and these were my findings. So this gentleman has features of upper motor neuron, asymmetric weakness of the lower limb with sensory level at T12, which and this is suggestive or in keeping with the spinal cord hemisection syndrome, otherwise known as Brown-Sequard syndrome. Okay, and the evidence for this is that it's increased tone with clonus. It's got MRC grade 2/5 power on the left side and 3/5 on the right. There's increased deep tendon reflexes in knee jerks and ankle jerks. Plantars are also upgoing bilaterally. There's impaired sensation with loss of pain and temperature on the left side up to T12, and joint position sense and vibration sense was above the knee on the left, and proximal toes on the right, respectively. Okay, and it can be a bit, yeah, complex at times. Now there is impaired coordination bilaterally, but what's on the left? There's a midline scar at the back, straddling T10 and L1 area. Peripherally, now I've moved centrifugally now. So peripherally, there is a walking aid and customized footwear at the bedside. So to complete my examination, I would like to do a digital rectal examination, examine the cranial nerves and the upper limbs. Do a full chart inspection. And I will also take a full history, focusing on past medical history, trauma, social and family history of neurologic disease, as well as look at his medication list. The differential diagnosis is a bit broad. If the pathology is in the lower limb alone, my differentials will include cord compression from either mechanical cause, such as trauma, tumor, or space-occupied lesion, or non-mechanical etiologies, such as CNS demyelination, syringomyelia, etc. To confirm my diagnosis, I would arrange an MRI spine, routine and specialized blood, including autoantibodies, and also do a CSF examination for routine constituents and oligoclonal bands. Management will be MDT-led with neurologists, spinal surgeons, CNS nurses, physiotherapy for mobility, occupational therapists for home and workplace adaptability, and podiatrists for foot care. If CNS demyelination is confirmed, medical treatment will include disease-modifying therapies, surgical intervention for release of compression in the acute setting, for example. So this is a bit very textbook-ish. I sort of coined this all from my head, okay? But it sort of captured the extent to which you can go and the latitude you can go when you're making your presentation. Basically, you can actually just surmise your whole essence of that station by your communication alone. And you know how communication is very important in the NHS. Okay, so you may not do much, but if you communicate much, you you still pass. Because the question is going to come, okay, if you're going to do it, or if you didn't do this, what will you do? And that's obviously that will be easy for you, and you just go talking about it. So in summary, um, examination is key. Vindicate your differential diagnoses, um, know your investigations, just four of them in neurology, and hone your presentation skills, fine-tune your presentation skills, following structure. The other thing I would just like to say is that you could present as you examine, okay? So mentally, you keep a mental picture. If you started with tone, power, reflexes, just present in that order so you don't forget, okay? Or if you've mastered it, you can just start with the pathologic summary and say, I've got upper motor neurons weakness, as I've done here, and then you break it down, and then you just go on talking about differentials and investigations and so on and so forth. So if there are no questions at this point, shall we have our volunteers and we can get started?
So I think we have Fintan Devine going first. Hopefully, I've pronounced that correctly.
Cool. Now, I love it, and
Perfect.
this is just my own personal. I love it when you put all your videos because now I know I'm not talking to a ghost. Okay. But if you can't, no problem. But just know, you will really gladden my heart if you put on your videos. First of all, it shows confidence that you're ready to be there. Okay. So it's a pass already. And so whatever happens is just, going to be, yeah. So thanks. Is that how do you like to be called?
Fintan is good. Thanks very much, Sonny.
Great. Great. Nice. So take a deep breath. You'll be doing station three. You've just finished the cardiovascular bit and you are moving. The bell has gone off, and here you go. So start off. I'm the patient. Do whatever you want to do with me.
Okay,
Don't
so
hurt me. Yeah.
so to start off, I'll have a look around the room to see is there anything obvious in the room.
Sorry, my bad. My bad. My bad. Jelani. Sorry. Are you able to please just time us? Just stop. You can let us know if it's 2 minutes or the point mark. Now, usually the exam is 10 minutes, but we'll do 8 minutes because of this presentation. Okay, 8 minutes. So you stop. You can let us know when it's 6 minutes, Jelani.
Will do,
Thank you so
yeah.
much.
Will do, no problem.
Thank you. Go for it.
Okay, so I come into the room, I'll have a look around and see is there anything obvious, such as any walking aids, any foot orthoses, or any medications. And then,
No,
so I'll do a general inspection of the patient. So I'd be looking to see is there any sign of any muscle wasting anywhere in the body? Um, does he look like he's got normal power in his arms and legs just from the end of the bed? And then I,
no, no. It's just cranial examination. Cranial.
you
Yeah, just
know,
focus on cranial.
so
Yeah.
then inspecting the face. So first of all, I would have a look at his face generally, look for any obvious asymmetry.
Yeah,
So
as you can see. Tell me what you find. What you find there. Just
so whenever his
well,
face when his face is relaxed, it looks fairly unremarkable. Then when he tries to smile, the there's weakness of the right side of the face. I think I'm
okay.
trying to
So
close his
you've seen the
eyes.
face. You've seen the face. What other thing do you want to examine? Just yeah, you're doing the cranial. Let's make it a bit real. So what other system? You've seen the face. That's the face. What other questions do you want to ask? What other examination do you want to do?
So I would do an examination of his eye movements and
Okay, eye movement.
and then
Yeah.
power the fifth cranial nerve. So looking to see jaw opening, eye closure, the
So
sensation in
what
the
are you
face.
looking for? What are you looking for in the eye movement?
So to make sure that they're normal, I
Yeah,
suppose
they're normal.
if there was yeah, if there was some sort of weakness of the eye movement, it could point towards some kind of grouped cranial nerve issue, like cerebellar pontine angle or
So it's got a six nerve palsy. Six nerve palsy.
So, and is that on just one eye or both eyes?
So it's got a six nerve palsy on the right.
On the right eye, I see.
Yeah.
And then on examining his visual fields, is there any obvious visual field deficit?
So no,
And then in terms of his vision, is his vision normal or is there any loss of vision?
visual acuity is normal.
Okay. And then next, I would move on to testing the power in his facial muscles. So cranial nerve 7. So I'd be asking him to close his eyes and try
Yeah,
to
that's
resist
what
me
you
open.
see. That's what you see on the picture. Yeah.
He
So
tries to
move
close
on.
his eyes. And then puffing out his cheeks, yep,
Again, it's weak on the right side.
weak on the right side.
Yeah, yeah,
And then I would do an assessment of his hearing. So to see is there any loss of
what?
hearing on that
Yeah,
right ear.
so yeah, yeah. What will you tell me how you do it? What are you going to use and what are you going to looking for?
So I would cover his left auditory meatus and then just make a sort of rustling sound just at the right ear and just ask him, can he hear it okay? And then you could
Okay.
also do the sort of high and low frequency numbers as well, stand behind him.
Okay. Crudely, he's got some hearing loss, but that's crudely. So move on.
Okay, so then I'd be looking at nerve 9, so glossopharyngeal. So I would ask him to press his tongue to the cheek, I think, on the each side and see if it's weak either way.
Yeah, he's got some weakness.
And is
How
that
would you
just
confirm
on
that? What would you? Yeah, yeah, got some tongue weakness.
and is that just on the right side? Pushing it to the
So the
right?
tongue is yeah. So the tongue is deviated.
Okay. And then you would assess his swallow and his gag reflex, but maybe not in the exam, but you could give him
Yeah,
something to drink
yeah.
and see.
He's got reduced gag as well.
Hmm. And then I would do his neck rotation for the cranial nerve 11 to see
Yeah, yeah. He's got some weakness, some asymmetry, as you can see on the shoulders. Some asymmetry.
hmm. And then shrugging the shoulders. Is
Yeah, he's
he
got some asymmetry. He couldn't shrug well on the right side.
okay? So
Both side, but
then,
worse on the right side. Yeah.
so he's worse on the right side.
Mm.
So I suppose putting it together at this stage, having examined his cranial nerves, there's clearly quite pronounced weakness on the right side. The one thing I forgot to assess was his sensation on the right. So is there a normal sensation on the face, or is there loss of
Um,
sensation on the right side?
How are you testing that? What are you using to test that?
So I would use a cotton wool bud on the face,
Mm-hmm. And
and
how are you testing it? What distribution? How are you testing it? Tell me what distribution are you
so
testing?
the three divisions of the trigeminal nerve. So I'd be testing just on both cheeks. I think that's the mandibular
Okay.
distribution, and then the higher up as well on each side of the forehead.
Yeah. So he's got some impairment in V2, V3 distribution on the right.
Cheers.
There's 2 minutes left.
Okay. Do you want to
Um,
present your findings? That's the end of your examination. We'll get better as we go on with this. Yeah. Do you want to just do a nice presentation on the differentials? Just carry on.
okay. So I've examined this man who appears to be in his 60s or 70s. My main positive examination findings are weakness affecting the right side of his face, as well as loss of sensation on the right side of his face in the V1 and V2 distribution. I also have found that he's got weakness on neck rotation to the right, as well as shoulder shrug on the right, as well as a deviated tongue and loss of gag reflex. And he's also got a right-sided sixth nerve palsy, and grossly, he's got reduced hearing on the right side as well. But in terms of the rest of the cranial nerve examination, his visual fields are normal. He's got no obvious loss of vision in either eye. So putting these examination findings together, looking at it, I would think that he has got so he would have uh and some kind of lesion that's causing weakness and loss of sensation affecting the right side of his face and his shoulder. And my main differentials for this would be something in the brain. So I think at his age, stroke could be a possibility. Um, I think that, you know, given that he's got a sixth nerve palsy, it doesn't really fit with a stroke in fairness because he's lost hearing as well. So maybe it could be more of a space occupying lesion. Um,
I think
and
that's your
if it
time up.
was
So stroke special requirement lesion, how would you investigate? How would you manage?
So, first of all, investigations at the bedside would be a set of observations, looking to see is his blood pressure raised, which might raise the possibility of stroke, and checking for any atrial fibrillation, checking his medications to see is there anything there that might put him at risk. And then, in first investigation, would be some brain imaging. So, I think that if it was in the acute setting, you'd be getting a CT scan to see if there was any bleed in case he was someone who may be a candidate for thrombolysis. But if it was a chronic setting, you'd be going with an MRI of his brain to see if there was any lesion there that could explain his symptoms.
So how would you manage?
So a patient like this would need a multidisciplinary team approach. Um, depending
All
on
right, time up. Yeah, time up. So well done. Well done, Fintan. Am I right? Or is it Divine or which is your first name?
Fenton. Fenton's the first name.
Fenton. Yeah, Fenton. Okay. Yeah, how did that feel? How did that come across?
To be honest, I felt it was
Hmm.
quite difficult because I didn't feel like I could understand what was going on because it didn't really fit with anything that came easy to me. When I first saw it, I thought it could be a Bell's palsy or something, but then it seemed a lot more than a Bell's palsy whenever we got sort of into it.
Okay, lovely. Does anyone have a comment or two to just make or before yeah, like I said, we're gonna have a number of them today, hopefully within the shortest possible time. Yeah, anyone? Oh yeah, so I can see from Sharafa. So CPA, what do you mean by CPA? Sharafa put up CPA in the cerebellopontine angle tumor. Lovely. Yeah, that's great. Brainstem stroke. Great. So let's come in here, okay? So what we've got, Vinton, we've got a patient with multiple cranial nerve neuropathies, okay? From cranial nerve 6, 7, 8, 9, 10, 11, 12. The whole of the lower cranial nerves are affected. Well, the
Hmm.
last four cranial nerves are in the medulla, okay? So it's lower down, okay?
Hmm.
And six and seven, six is a false localizing sign. So I don't normally we don't take six seriously in neurology, okay? It's probably just say seven because of the obvious there. And then the other thing is the fact that what sort of again going back to the basics, upper or lower motor neuron, that informs your differential. That's where it flows from. That's the well in which the differentials flow from. It's all lower motor neuron type. Okay, everything that you see there, lower motor neuron type, the facial nerve weakness, you can see the whole of the upper. There's lots of upper wrinkling there, all lower motor neuron type. And for the tongue as well, I'm not sure if you mentioned it, but I think you didn't know it was deviated to the ipsilateral side as well. Okay, that means the lower motor neuron type as well. Okay, so that means whatever is happening is beyond the nucleus of the cranial nerves. It's not in the substance of the brain. Remember, the nucleus of the lower cranial nerves are in the medulla. Okay, but what you're saying is the lower motor neuron picture. So that means whatever lesion is happening outside of that area. So where else could it be? Okay, so if you go to our vindicate, so the next thing you need to vindicate this, okay? Could it be vascular? I mean, very spot on. I like the way you went. If this happened in the acute setting, I'll be thinking of, you went to stroke because it's vascular. Or especially you mentioned trauma, okay? Trauma or some kind of surgical damage during surgery for, a neck or a skull-based tumor, blah, 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 okay? Or if you went in your presentation to say, okay, I would like to take further history of constitutional science, like weight loss and all that. I'm thinking of malignancy, probably had a malignancy that was resected, and so on and so forth. Okay. And the other thing, let me show you this. You didn't look for scar.
Oh, yes.
Always, now, most of you guys in neurology think, oh, there are no scars in neurology. There are scars. There are scars in neurology. Okay. look for scars anywhere back. If you examine the cranial nerves in this case, you know, just feel, look for scars. That's a CP angle tumor. This patient had an acoustic neuroma. Okay, and yeah, and then the other thing I like to say, this came up in my own exam actually. Um, and for the you hear that candidates are not allowed to do Renes test or Weber's test, but they let me do it. They let me do it. So don't, yeah, I used to believe that, but after that experience, I tell people you can be asked to do it. So I was asking you, you said you're going to do crude test. No. If there are no instrument, or at least say that first, that I would have loved to use and look for what sort of tuning fork would you use? What is the frequency of the
Well,
tuning fork? Sorry?
I guess 200.
No, it's 528, I
528.
believe. Yeah. 528, yeah. Yeah, okay, yeah. Somebody correct me if I'm wrong. 528 or 516 or 12. I think it's double, something like that. But it's in the 500s, okay? So that's the first thing because there were two tuning fork there. One was 128. 128 is the one you normally use for peripheral nerves. So the one for 528, I believe, or 516 is the one that you use for hearing test. Okay, Weber's and Reams test. Okay, Ryan's test. Okay, and yeah, they made me do it. So you need to know where the lateral lies to. Okay, in this patient with the sensorineural deafness. Okay, his Raynaud's test, which test for conduction was better in that ear, but air conduction was better in that ear. Bone conduction was lateralizing to the contralateral ears. Okay, so you need to know that. All right, but well done. Other than that, I think you flowed very well in the rest part management. Like I said, I think I made it easier. Investigations in neurology are just four part: MRI scans, blood tests, and so on and so forth. Yeah. Any question from you?
Yeah, I was just
Or
wondering, I
anyone else?
thought during it of the CPA tumor, but from memory, I think, is it cranial nerves 5 to 8 that are implicated, or I might be mixing it up with another sort of grouped cranial nerve lesion, but then in this case, was it the surgery that might have damaged the other nerves when he was having it removed?
Yeah, so possibly, or it's a very large tumor that
Hmm.
has, spread to contiguous areas. Yeah, yeah, but the whole of the lower cranial nerve were picked up. Yeah, but commonly speaking, usually cranial nerve 8, 7, 9, yeah, but 5. Surprisingly, I saw that the 5 sensory part of 5 is involved, but wasn't I deliberately it wasn't involved in this case. But usually sensory parts of 5 can also be involved as well. So CP angle tumor, it's got these names: vestibular schwannomas, acoustic. Is a benign tumor, actually slow growing, that affect the vestibular portion of the eighth cranial nerve. Is the most common non-malignant primary tumor after meningioma, and primary tumors accounting for nearly 90% of CP angle tumors. It can be associated with neurofibromatosis type 2. Um, and also it presents with hearing loss, dizziness, tinnitus, vestibular dysfunction, facial nerve mass effect, and so on and so forth. So commonly, cranial of 8, 7, 5 are affected, but you can also have 6, 9, 10, 11, and rarely 12. In this case, this patient, yeah, obviously, maybe surgical damage or some kind of very large tumor. Diagnosis by MRI, again, treatment is MDM-led oncology, neuro-oncology, otorhinolaryngologists, ENT doctors are all involved here. Okay, and this is how the tumor look like. In case you are wondering how, where, and where does it look at? That's the CP angle area, which is just, that's where the ear is, cerebellopontal angle. So it's axial view, axial T2. And anatomically speaking, so you can see so you see why most of the nerves can be affected. Okay, so because
Hmm.
that's the location of the angle tumor. Yeah, so if it's a very big tumor extending out to that area, it can pick up on anything. Right. And you didn't ask, and if you had looked, if you, well, sorry if you did, but I didn't think, even if you didn't ask, if you knew that, okay, I'm dealing with a CP angle tumor here, you say, I would have loved to look out for things like nodules, skin lesions to suggest neurofibromatosis. I also like to do a fundoscopy to look for leaf nodules and so on and so forth. That's a distinction. You probably get an award, a national award if you mention that. Okay. But yeah, that's where we stop with this today. So if we got time for another one, like I said, It's up to you guys. If you want to, I'm ready to go as far as you want to go. If you want to stop now, we can stop now. But yeah, we've got, if there's another candidate that's willing for the next case.
Thanks
Thank
very
you,
much, Tony.
Finton.
Thank you. That was
Thank
great.
you. Yeah, I've got
Guys, please do
so
volunteer. I
somebody
think
asked
it's
how are
very
the
beneficial.
images of the man explained. So that's not the image of the man. Okay, that was an example image to show you how a CP angle tumor looks like on the scan where it's located. Okay. But if you want to push it, that tumor is on the right side, which corresponds to the patient anyway, but it's not a scan of the patient. It's not a real patient. Yeah, thank you. Um, Finton is ready to do another one. That's cool. Yeah, that's fine. When is your exam, Finton?
So I've actually already done the exam. I've passed it, but I was keen
Oh,
just to come along
there.
because it's good to learn.
Congratulations. Congratulations. So, congratulations. So you shouldn't be doing this.
Well,
Um,
it's good though,
yeah, but
but I don't want
yeah,
to take the
maybe you
place
want to
of
be
for someone else.
do you want to do neurology training?
Well, I'm doing GP at the moment, but the neurology would be really interesting, and I
No
think it's
worries.
good
That means
whenever you
less
see.
referrals. Yeah, less referrals from you when you are a GP. Just let me know where you are. I'll probably work there. So yeah, for the sake of time, Finton, if you're happy to take the second patient, examine the motor system of the patient.
Okay, will I just go ahead? So I'll have a look around the room to see is there any mobility aids, any medications, or any foot orthoses. Nothing obvious.
Okay.
So next I would,
Um,
sorry.
yeah, carry on. Next, you do what?
So
Nothing
I would
obvious. Just carry on.
So I would ask the patient to walk after I've done a general inspection of him just to see is there any obvious abnormalities on inspection. So I'd be looking to see is there any evidence of muscle wasting or any obvious abnormal movements.
Okay. So this, sorry, the slides are jumping up. So, but yeah, that's the movement. If you want to see the movement.
Cheers. So when I'm looking on there, I think he's got quite a broad-based gait, and it looks as though the power in both legs is
Yeah.
fairly equal.
Next, what do you want to, yeah, what next do you want to check?
So I would maybe next I would ask him to put his both feet together and do a Romberg's on him, see if he's steady enough to stand.
Rombeck is Rombeck is negative.
I see. So that would imply that he has, it's not a sensory issue at play here.
Yeah. So what else
So,
do you want to do?
so next I would ask him to lie on the bed and do a test of his tone
Mm-hmm.
in the legs.
So tone is reduced.
I see. And then next I would do the power in both legs. So starting with hip flexion on both legs.
Oh, it's normal.
And is that on all parts of the leg, like knee extension, knee flexion,
Yeah, power is generally normal.
so normal power. Then I would test his coordination. So I'd ask him to do this heel shin test
Okay. Then the lower limb, yeah, it's
on the lower
impaired.
limb, yeah.
Yeah, it's impaired
Is impaired.
bilaterally, but yeah,
Is it both
yeah, it's
sides,
impaired
sorry?
bilaterally. Yeah, it's on both sides, but it's more prominent on one side.
Okay. And then next I would do his reflexes. So starting with the knee reflex.
Normal reflexes globally.
Okay. And then so I've done next I would do a sensation. So I would do pinprick, so across all
Intact,
dermatome, intact. And then I
intact.
would do his vibration sense, starting off with distal. So I would start with the interphalangeal joint on the great toe on the left
Again,
foot.
normal. Yeah,
Normal.
anesthesia is at the distal toe. Prosection is at the distal toes as well. Yeah.
Okay, so I think it may be a cerebellar pathology that could be going on. So I'd ask the patient to speak. So I'd ask them to say baby hippopotamus. And next I would do his eye movements to look for nystagmus.
This is what you find on the eye movement.
So
Okay, what else?
so I would next do a finger nose test on the upper limb.
Um, Finger nose is impaired as well, like the lower limb. Yeah.
Okay. And then I would have a look and see is there any scars around the back of the neck or the head.
That's what you've got.
Okay.
1 minute
And
more.
sorry.
1 minute more.
Okay. So I'm just thinking, is there any other examinations to do? I suppose if there's time, I would do an examination of his upper limbs, testing the tone in them.
All right, you can present now. You can just start off presenting your findings and manage the patient.
Okay. So I've examined this middle-aged man today. My impression is that he has a cerebellar lesion, or pathology going on. He has got a broad base gait with impaired coordination on both legs, but worse on one side more than the other. He's got um, nystagmus, and in addition, he's got ataxic speech, um, or rather staccato speech. Um, so, and he's both his upper and lower limbs are affected with poor coordination, and he's got a scar at the back of his neck extending up to the occipital region. So, my thoughts on this patient are that he may have had some form of lesion or tumor around the cerebellar area, and which has been removed and maybe has had some damage from that, or the alternative could be he's had trauma to that area, but I think that's
Okay, what
probably
are your
less likely.
any other differentials?
So my other differentials would be other causes of cerebellar issues, so that would include alcohol, um, also some of the more rare inherited cerebellar syndromes like Friedreich's ataxia, but I don't think
Hmm.
his examination's in keeping with that because he has I forgot to examine his plantar reflex, but he seemed to have normal tone. Um Other things could be medications that could damage the cerebellum.
Okay, how do you manage?
So in this case, if he presents acutely, my initial management would be to rule out stroke, since it's time critical diagnosis, so it'd be getting a CT scan and asking for the stroke team to see him. If he presented in a more chronic manner, my approach would be getting an MRI scan of his brain to look at the cerebellum and doing some blood tests.
Do you
Um,
think CT, do you think CT will identify a posterior column structure like the cerebellum adequately? Why would you want to start with the CT?
I think the reason for starting with the CT would be to make sure there was no acute issue like a bleed in the cerebellum or, you know, some form of compression. But I think an MRI scan would be a better form of imaging to look at the cerebellum.
Okay, how would you manage?
So it would require an MDT approach. So we would need physio and
All right,
OT.
time up. MDT is enough. That's fine. So that's okay. Again, in retrospect, yeah, I mean you've passed, which is great. Passing gives you some kind of confidence. Passing, yeah, it makes you realize that you're actually knowledgeable, kind of. Okay. But yeah, so yeah, that's a good one, Finton. And for those listening to Finton, I think Finton, you can do indirect learning from what Finton is doing. Your examination, you cool, calm. I must appreciate your demeanor. Uh, yeah, you calm. You're not perturbed at all. Um, and then your examination was very sequential. Um, I don't feel I need to tell you anything because you've already passed the exam. But i- in differential diagnosis, I can see that you bit, you know, it's okay. You kind of struggle initially, but I think if you if you say this is cerebellar syndrome, okay, this patient has got Danish, okay, most of the Danish signs, okay. If you say he's got dysmetra or you didn't do this diadokinesia, but that's not a problem. It was ataxic. He's got nystagmus. Got I didn't hear you search for tremor, but he's got lost speech and hypotonia. So this gentleman got cerebellar syndrome. The differential diagnosis of cerebellar syndrome are one, just follow Vindicate, okay? Vindicated in the acute setting, I think of vascular causes like hemorrhage, cerebellar hemorrhage, okay, or cerebellar arteriovenous malformation that have bled, or this patient may also have had a cerebellar ischemic stroke, or this patient have had a cerebellar tumor. Other causes are infections, inflammation, infections like cerebellitis, viruses, bacteria that can cause cerebellitis, paraneoplastic syndromes, drugs, phenytoin, can affect the cerebellum. The list is long, okay? And then, of course, you move on to different investigations, which is going to yeah, in the acute setting, CT head to rule out hemorrhage, or ideally for posterior structural tumor, posterior fossa structures, MRI is the imaging of choice. And of course, management will be MDT led and so on and so forth. Yeah, good one. Good, good. So, yeah, and the other bit is Rombeck sign is not a sign of cerebellar ataxia, and I'm glad you knew that. Yeah, in the physical course where I looked after a few candidates, I saw this confusion about Rombeck sign, being mentioned as a form of cerebellar sign. It's not. Okay, it's negative in cerebellar disease. So cerebellar Rombeck sign is a sign of sensory ataxia. So if you've got ataxia, your task is to distinguish whether this is central or peripheral. In other words, whether it's from the cerebellum or from the peripheral nervous system. And there are two things that distinguishes cerebellar ataxia from sensory ataxia. Apart from the Rombeck sign, every other thing you find on sensory ataxia, you also find on cerebellar ataxia, except nystagmus and dysarthria. Those are the two signs that gives it away. Once you find a patient with ataxia, all you need to check, and once you've done the Rombeck sign out of the way, all you need to go look out for is to see whether there's a nystagmus there or a dysarthric speech. Once those two are not there, you're likely dealing with sensory ataxia. If they are there, you're dealing with a cerebellar ataxia. Now, you could also have upper motor neuron signs accompanying cerebellar signs. Once you see that, that changes the game. Yes, you're still dealing with a cerebellar syndrome, but with upper motor neuron signs. The differentials are going to change. Stroke could still be a differential, okay? However, if you think of things like multiple sclerosis, CNS demyelination as well, because of the presence of upper motor neuron signs accompanying cerebellar syndrome or signs. Is that all right? Yeah.
Yeah.
So, differential diagnosis of cerebellar syndrome, as I've mentioned, yeah, again, structure is key. Immune mediated Bickerstaff encephalitis, a brainstem encephalitis actually, but you can also have cerebellitis from some kind of autoimmune encephalitis affecting the cerebellum. Paraneoplastic, phrenic ataxia, like he mentioned, spinocerebellar ataxia. Again, they will have upper motor neuron signs as well as cerebellar signs. Just like if you think of multiple sclerosis, if the patient is younger, you would think of spinocerebellar ataxia because it's a genetic condition. Um, Friedreich ataxia, yeah, can happen, but usually there are other signs. Patient is going to have those phenotypes in the legs, and also patient has dysphagia. They may have diabetes, but they do have lower motor neuron signs, actually, not upper motor. Okay, but they have posterior column signs as well. So they will have Rombeck sign with positive in Friedreich ataxia. Yeah. Okay.
Tony, I just had a
Is that
question. Sorry.
Mhm.
Just about that last case, I just noticed would stroke also be a cause of cerebellar syndrome, or is it not really that common, like a
So yeah,
infarction?
yeah, if you have a cerebellar hemorrhage or
Hmm.
stroke of any form, yeah, it could be a cause of cerebellar syndrome. But I'm sure I get what you mean. You expect upper motor hemi, what they call lateralizing upper motor neuron signs, okay?
Hmm.
Yeah, but that's not what is present here. Although if you have a stroke or hemorrhage in the cerebellar vermix, which is the central area, you're going to have some kind of both sides being affected.
Hmm.
Um, but yeah, that's practically that can happen. So mentioning stroke in the diagnosis, a lower motor neuron sign does not exclude stroke, like I said. All you need to say is that if this happened in the acute setting, okay, I'll be thinking of stroke, and that matches the fact that your your reflexes and tone they were normal, okay, at that time. But if you come back again in 24, 48 hours, the reflexes would have picked up and there will be hyperreflexion, hypertonia. So yeah, it's in order for you to mention stroke as a differential. And with that scar, I think cerebellar hemorrhage should be on the first list. Cerebellar hemorrhage and cerebellar tumor rather than ischemic stroke per se, because you didn't find upper motor neuron signs. That's not to say that you can't have upper motor neuron signs with cerebellar hemorrhage, which is also a form of stroke. You can't have it, but for the sake of this presentation, mentioning stroke in any form is an acceptable differential in the acute setting. Okay.
Thanks very
Yeah,
much.
that patient had an AVN, had an arteriovenous malformation, which was discovered incidentally because she was having a long history of gait ataxia. Nobody picked it up until a junior, I won't mention the hospital, decided to do a scan. And they saw something, a very good radiologist saw something on the CT scan and ordered an MRI scan. And that's how they discovered the AVM. Unfortunately for her, at that same time, they were discovering it, the AVM ruptured and she bled. She became unconscious. She had emergency surgery. Yeah, no history of
Mhm.
hypertension, stroke, no risk factor, and all that. So that was a live patient, but I just kind of tweaked it a little bit. Cool. And then if there are no other volunteers, we just go to let's see what was the significance of the posterior scar in this context. Surgery. Okay, patient has cerebellar hemorrhage. He needs to have CNS decompression, brain decompression. Okay, decompressive surgery. Um, Differential diagnosis tumor, good point. Hypothyroidism, yeah, good point. Paranoid syndrome, yeah. Multiple sclerosis, good. Yeah. Um,
I think
no,
we may have.
Finton, we're not going to let you do another one. Jelani, if there are no other person, we'll just round off if
I
that's
think there
okay.
is one person who might want to do one.
Okay.
After P, if you're on, feel free
Yeah.
to turn your screen on and your audio on.
Uh, Hello.
Thank you, Finton.
Thanks, Tony.
Hi, Dr. Stunning.
Yeah, Abdul.
I'm not in around the normal surroundings, so is it okay if I can just go through with the audio?
That's fine. Not a problem at all.
Sure.
Yeah.
So, to start off, I would like to look around the surroundings and notice that the patient's on a wheelchair. I'll look around for any bedside medication, and from there, I'd like to look at the patient themselves from the end of the bed, see if there's any obvious deformities, any scars, any signs of distress. From there, I would, after all the greetings and everything like that, getting consent, etc., I would like to ask the patient to close their eyes and stretch their hands out and see if there's any
Okay.
pseudoathetosis. I'd like to
There
have
is
them open
pseudoathetosis.
their pseudoathetosis. I'd
There
ask
is
them to,
pseudoathetosis bilaterally.
oh, okay. From there, I'd like to ask them to turn their hands around, outstretched, close their eyes to see if there's any pronator drift. Okay.
There
I
is
would
some
then,
drift. There's pronator drift
okay,
on the left side. Yeah.
left side. I'd then like to have them keep their hands outstretched, cock their wrists back to assess for and look at the back for any scars or any winging scapula.
And she doesn't have any scars.
Okay. I would then like to have her to tap her fingers, her index and her thumb as fast as she can.
Okay. There's no impairment. It's clumsy, but there's no impairment in
Okay.
coordination.
And then I would like her to grasp her, make a fist as hard, squeeze it as hard as you can, and then open them as fast as she can.
Yeah, she can't do that, but if she's a bit clumsy as well.
I see. Okay, from there, I would like to start off with the tone, assess for any spasticity or rigidity.
So the tone is quite brisk, brisk on both sides, but worse on the left.
Okay. From there, I would like to check for power, any shoulder abduction, any elbow flexion, extension, wrist flexion, finger adduction, and if
So she has abduction weakness. She has elbow weakness as well. Yeah, she got weakness, at least 3/5.
3 out of 5. Okay. What about thumb opposition, finger abduction, finger adduction?
So the flexors are not that weak in the fingers. They're not, yeah, there's no flexor weakness in the finger.
Okay. And then from there, I'd like to check the reflexes of the bicep, tricep, and brachioradialis, please.
Again, all reflexes are brisk globally. Thought you've mentioned that before.
Okay, I apologize. And
Mm.
the Hoffman sign, please.
Hoffman sign is positive.
Bilaterally. Okay. From there,
Bilaterally, yeah, but asymmetric,
okay.
one more than the other, yeah.
I'd like to assess for dysdiadochokinesia or finger to nose pointing, please.
Again, it's intact, but clumsy. I think you've said this before, but you can go on.
Uh,
Yeah, no problem.
okay. And then from there, I would like to assess for the sensation using find as a pin and using the forehead as the reference point, assessing bilaterally from the middle finger upwards.
Yeah, she has patchy sensory loss in C5, C6 um,
Okay.
distribution, yeah.
And also want to assess for the soft touch, then use the in the same distribution, please.
So soft touch is impaired.
Mhm. Okay. Vibration with the 128 hertz tuning fork on the distal interphalangeal joint of the middle fingers
Yeah, so palanesthesia or vibration sense is at the wrist.
up to the wrist. Okay. And from there, I would like to inspect the neck and the spine. I know you said there was no scars earlier for the scapula and everything, but was there
Sorry, say that
anything?
again.
I
Yeah.
know I noticed you said that there was no scar by the scapula and everything like that, but was there any scars at the neck on the cervical or anything like that?
No scars at all.
Okay. So I've ultimately to complete my examination, I would like to do a full cranial nerve exam as well as lower limb
All right,
examination.
so yeah, you can present your findings.
I was asked to examine this lady upper limb examination. On general inspection, I noticed that she was in a wheelchair. I was not able to appreciate any medication at the bedside. On closer examination, I noticed that she had a brisk reflexes as well as increased tone, suggestive of an upper motor neuron. Furthermore, I was unable to appreciate coordination as it was clumsy, and she had decreased sensation and from her C5, C6 soft touch and pinprick, whereas she also had decreased or impaired vibration proprioception up to her wrists. Putting all of these findings together, I believe my patient has an upper motor neuron lesion somewhere potentially in the cervical area. My differentials in this case would potentially be that she either has a cerebrovascular accident or a demyelinating lesion or a space occupying lesion such as a tumor or abscess. I would like to complete my examination by doing a full set of observations, taking full history from the patient, taking full blood count to assess for any considering macrocytic anemia, CRP in addition to rule out infections, getting B12, eugenese, folate to assess for any electrolyte abnormalities. Ultimately, the patient will require a CT of the head to rule out any ur- um, urgent bleed or ischemic stroke, and ultimately will need an MRI of the brain and spine. I would like to work the patient up or manage the patient in a multidisciplinary team approach with the neurology and neurosurgery team as well as the neurology team and PT, physical therapy, occupational therapy. If I notice that their patient also had any issues with their swallowing or anything like that, I also consider speech and language therapy.
Okay, so if obviously you mentioned that to complete your examination, you do a cranial nerve examination. So what would you be looking out for in the cranial nerve examination?
In this case, I would be looking for, I guess, hemianopia. I would also look for any sort of facial upper lower motor neuron lesion with
Okay,
the C7.
okay. Well, if this patient has got an INO,
Yes,
what would be your topmost differential?
multiple sclerosis or the CVA.
Okay. What would you find in what auto antibody would you assay for?
Um, antibody wise,
What
uh,
auto antibody would you assay for to diagnose multiple sclerosis?
I'm not sure about auto antibody, but with regards to CSF, I would say oligoclonal bands and kappa free light chains.
All right, that's the
Mm,
time.
no problem.
Well, this is a pass. No, 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 yeah, this is a clear pass as far as this is concerned. But yeah, just the last bit, you can
Yes, sir.
find oligoclonal bands in serum as well. Okay.
Yes, sir.
Of course, I perceive that I mean you are a high flying candidate, so I just wanted to check with that with you. Oligoclonal bands in CSF and in serum okay, you're normally tested together because normally if I do your oligoclonal bands, okay, you're going to find some of us if in the population there are a level of oligoclonal band positivity. Okay, so checking it on CSF and see that disproportionate increase is how they make the diagnosis. Okay, and there is a form of oligoclonal bands that the chemical pathologists will assay for. You don't need to know the details of that. In 2027, 2024, new McDonald criteria came out for multiple sclerosis diagnosis, which have sort of expanded the diagnostic nets. So you have dissemination in space and time radiologically. So there are more areas in the brain that you now look at for. The traditional four areas were usually the juxtacortical areas, periventricular white matter areas, cerebellum, and spinal cord. But now we now have other areas. So there's the what they call the central venous sign and the perimagnetic rim lesions. Okay, and also there is another marker for multiple sclerosis. It's called this free kappa light chains. Actually, that is topping up oligoclonal bands. So that is number one ahead of oligoclonal bands as we speak. So free kappa light chains are what we now check for in CSF and for multiple sclerosis. So multiple sclerosis is a common cause of upper motor neuron signs, can come in any shape in communication stations, in neurology station, lung cases. So be aware. Drug treatments, again, disease modifying therapies, there are a legion of them, but always go for MDT approach and you will be fine. Thank you. That was, in my opinion, I don't know if you have any questions, Dr. Abdul.
No, no. Thank you so much, Dr. Sunny. Appreciate it.
Yeah, yeah, that's spot on. Yeah. Yeah. Again, that's multiple sclerosis. So these differentials here were multiple sclerosis, bilateral ischemic stroke, syringomyelia, or spinocerebellar ataxia. Obviously, she must have lived that long because, if she has spinocerebellar ataxia. Um, just to mention, she did have, when you say clumsy, because this patient has been on treatment, so some of the signs would have been blurred. Okay. So, um, even though you didn't, that dysdiadokinesia, dysmetria, wearing that clear, I did say clumsy. I kept saying clumsy. That's because, this patient have had been on treatment. Those signs were there initially, but they've been sort of getting blurred. And so, yeah, so she did have upper motor neuron signs, subcerebellar signs, posterior column signs as well. So if you have those three together, you'll be thinking of multiple sclerosis, as well as these other differentials. Syringomyelia has a typical pattern of sensory impairments. So you need to know that what they call dissociative sensory impairment as well. But yeah, it's just a part of the differential, but that's not what we're dealing with here. But it's possible for patients with syringomyelia to also be on a wheelchair. So differential diagnosis of limb weakness for pure motor weakness. You have things like post-polio syndrome, heavy metal poisoning, degenerative causes like motor neuron disease. If it's a lower limb weakness, it's a variant of motor neuron disease called progressive atrophy. And then immune conditions like multifocal neuropathy with conduction block, CIDP, which is a chronic form of GBS, radiculopathies, brachial neuritis, etc. for lower motor neuron type weakness. For upper motor neuron weakness, again, multiple sclerosis, stroke, spinal stroke, hereditary conditions like hereditary spastic paraplegia, the other variants of motor neuron disease, which includes amyotrophic lateral sclerosis and primary lateral sclerosis, so like HTLV and syphilis. Yeah, so you can always check out differentials in your cases book. There's the cases for PACES that you got good, really nice differential listings there. Any questions? If there are no questions, let's see if there is any willing. I know we've time spent. We can round off. Which antibodies characteristic for MS? Yeah, oligoclonal bands. Yeah, that's the response to that. Chiari syndrome also could be one differential. Yeah, especially in the cerebellar syndrome case. Yeah, yeah. Someone who is this? Someone mentioned that Sammy. Yeah, Chiari syndrome could yeah be a differential, and not Chiari syndrome be a differential.
Sorry, it looks like we've just lost Sonny, and we'll just try and get him back. Bear with me.
Hello, I'm so sorry. Think I ran out of
No problem, Sonny.
just yeah,
Yeah,
so sorry.
go ahead. Yeah, if you,
Um, what's next here? Hello, can you hear me okay?
yeah, yeah,
Hello?
yeah.
Yeah. Right. So do we have anyone or should we just round off? Anyone in the chat willing to have a go?
I don't think
Hi,
there's anyone oh,
I'm
perfect.
Kai. If you don't mind, I'd like to have a go, but unfortunately, I can't. My phone doesn't allow the camera on.
Not to worry at all. I think I'll have to take back the camera thing off if that's a bit of a problem at this stage. Yeah. So don't worry about camera. I don't need your camera anymore. I changed my rules today. But thanks for those who came with a camera, but that's fine. Yeah, Kai, I'm happy for you to have a go.
Thank
Ready
you.
when you're ready. Yeah.
So first I'll walk in and introduce myself, clean my hands. If patient able to talk, I'll assess the speech if when they say the name and age. I'll have a
Yeah,
look in the room.
hang on, Kai. So this is where you need to make a mistake, okay? So don't worry. Lower limb examination should be telling you about speech at the very first instance. Carry on. Start again.
Um, I will walk in, wash my hands, and introduce the consent.
Mhm.
And then I would inspect the room for any orthoses, any um, splints, any medications, any wheelchairs, any
Splint
devices.
is negative. Yes, splint is negative. There are medications I will show you in a minute.
Yep.
What else do
Um,
you want to do?
I would first ask patient to walk where possible.
Lovely. So this is the patient walking.
Yep. I would then ask the patient to walk back and stand by the edge of the bed, and then
She's
feet together, eyes closed, while
So
I
Rombeck sign is positive.
rhombus sign positive. I would then get the patient to sit back down, and then as patient is standing, I'd like to inspect the leg for any scars, any wasting, any clear deformities.
No, none of these are there.
And then I'll make the patient go back to the bed, and then I would like to assess the tone by rolling the leg as well as lifting it from the knee rapidly.
Tone is reduced.
I would then perform a clonus whilst bending the
Tone,
knees
tone is
bilaterally.
reduced. You don't need to check clonus when tone is
Clonus,
reduced.
thank you. I'll then move on to assess power to get the patient to lift the leg off the bed, assessing the hip extension,
4/5
flexion, knee
ish.
extension, flexion.
Yeah. 4+/5, otherwise normal. Yeah.
Yep. And then I would move on to assess the patient's reflexes from knees, the ankle, as well as the Babinski.
So what will you? So
The expecting
reflexes are reduced. So what will you do with the Babinski? How would you do it?
with a wooden stick supplied, I would scratch the bottom of the foot from the bottom of the foot to the outer edge of the foot, and then to the base of the toe, big toe, and just like an outer circle ring.
Okay. So Babinski flexor, plantars are flexor bilaterally.
Thank you. I will then move on to assess coordination first. So the heel to the knee and drag it down the foot, drag it down the shin.
Yeah, it's impaired, struggling.
Understand. I would then perform a assessment of sensation. So cotton wool to the neck, to the base of the neck, and then over the dermatomal of L1s to S1.
What other sensation would you perform?
The cotton wool for soft touch.
Yeah, next.
And then for pinprick, and then for vibration with a 1 to 8 hertz.
So you got a stocking pattern impairment there.
Stocking pattern.
With vibration sense up to knee.
Up to knee. And I also do proprioception.
Proprioception is at the ankles.
At the ankles. Okay, thank you. I would like to request complete of examination by doing cranial nerves and upper limb assessment for the lady.
Okay, so present your findings.
So this is the lady whom I've performed a lower limb exam. Patient has a very unsteady gait with a positive Romberg. She has reduced power bilaterally, reduced reflexes, reduced sensation for touch and pain in a stocking distribution with proprioception and vibration loss up to ankles. This is a presentation in keeping with a bilateral polyneuropathy, sensory dominant. My differentials would include metabolic conditions like diabetes. Other causes will also include vitamin deficiencies.
Which vitamin? Which vitamin?
Vitamin B12 deficiency or folate.
Okay, how would you manage?
To start off, I think blood tests, including the vitamin deficiencies, vitamin blood tests would be useful, as well as infective markers to rule out infection, including assessment of the patient's drugs. Blood glucose monitoring is also useful to rule out diabetes as a cause, including HbA1c. Nerve conduction studies would be useful in assessing the nature of the nerve damage.
What would you find in the nerve conduction studies?
Nerve,
Given your most likely diagnosis, what would you find? What kind of pattern would you see on nerve conduction?
So if it were metabolic like diabetes, it would have an axonal loss. If it were a cause like a demyelinating polyneuropathy, then it would have a demyelinating nature with a reduction in speed.
Okay. If you have to give a medication, what drug treatment would you offer this patient?
So in the context of, I would like to evaluate the onset of this presentation. If it's a acute rapid onset, then
well done, Dr. Kai. Yeah.
Then
time up. Yeah. Sorry. Time up. Yeah.
I see. Okay. Yeah.
Yeah. But I mean, if you are being asked questions like clinical questions or medical questions like that, my understanding is that you've already passed. They're just thinking of whether to give you a 5-star or a 4-star. Okay, so don't worry. I was just that, obviously it's diabetic peripheral neuropathy. You did mention that you wanted to look at the bedside, so this was what was at the bedside, but you missed this. This patient have got a Libra device as well.
I see.
Beware. So yeah, duloxetine is the drug of choice for peripheral neuropathy, duloxetine. Other options are gabapentin, pregabalin, amitriptyline, if the patient can tolerate. So yeah, that was a good one. That was a good one. Do you have any questions?
No. I think, I mean, the differentials is very comprehensive and it's useful. So thank you very much for this slide as well.
Yeah. So beware when it looks so simple. Okay, they are going to be a bit picky. Okay. Diabetic neuropathy is a bread and butter, so they want to see you really go to town with it. Okay. For example, in mentioning your differentials, okay, structure is important. Okay, so if you say, if this happened, yeah, even though you've seen insulin and everything there, you just have to pretend a little bit that, okay, let me be open-minded. Okay, because that could just be a rare hair, a distraction, maybe TBS. Okay, so you need to say, if this happened in the acute setting, my differentials will include GB acute inflammatory demyelinating polyneuropathy. Okay, however, and then you say the negatives. Okay, however, this patient has got other signs of diabetics, insulin in the bedside. So I'm not thinking about that, but that's a plausible differential diagnosis, given that there's some level of weakness, okay, alongside the posterior column signs of vibration and sensory and pinprick impairment as well. The other thing I'd just like to feed back to you is, I was trying to stop you at the Babinski level. Now, you have to be careful, okay? Ideally, there is a device for checking Babinski. So most candidates use their thumb and they use the tip of the patellar tendon hammer. That is not technically right. So if you meet an examiner who knows, he will mark you down for that if you use anything other than what should be used. So always ask. There is a marker, a red pin, something like that. It's not always common, but if you ask and they say it's not present, at least you've ticked that box. So if you use any other soft thing, that's fine. What I tend to use is the pinprick, the neurotip. Yeah, the neurotip, the blunt part before you open it up. Okay. Yeah, you can use that with very supported with your thumb just to go through and warn the patient beforehand. So sorry, are you normally ticklish? I apologize ahead. This may be a bit ticklish. Otherwise, people are going to drag their foot, and there will be some level of awkward moment for you, which you don't want in the exam. Okay. And Babinski, so be careful when you say Babinski is positive, that means the plantars are upgoing. Okay. So I rather just say plantar response is flexor or extensor. Okay. Yeah. All right, yeah. Otherwise, that's a pass. So sensory predominant polyneuropathy, differentials again, immune, metabolic, nutritional, toxic, infections. You go to town with it. Okay. However, if it is sensory motor, so if you've got significant proximal motor weakness or distal weakness, you'll be thinking of more of GPS, and of course other hereditary causes, especially if this patient have got a footwear and orthosis around the area, and of course with classical features of CMT, peace cavals and all that, you and the sensory motor features, you think more of as Charcot-Marie tooth. Well, in peripheral neuropathy, whatever you mention is probably going to be fine as long as you situate it contextually nicely, okay? If this came up
Mhm.
on a consultation station, Dr. Kai, or a communication station, what would tell me one advice you would give to the patient? Just one.
Food
Let's say
checks
you're
and
doing,
eye
yeah,
checks.
that's not what I want
As
to
in
hear.
checking the food
Advice,
and checking the eyes.
not clinical. It's not in one non-clinical advice.
Non-clinical advice.
Mm.
Uh,
Can
um,
any can anybody, yeah, anybody can put it in the chat. Let's see if we've got some. Oh, look like there's no chat. Driving, yeah. Someone mentioned driving. So yeah, lovely. I'm glad that someone was able to mention that. So Kai, yeah,
yep.
yeah, that's it. Yeah. So and it makes sense, isn't it? The patient can't feel his legs. He can't feel the pedal,
Yep.
right? So yeah, to DVLA, I've included that a couple of years ago as a reason not to drive. If the patient got peripheral neuropathy, no driving. All right. Good job. Again, we can finish if everybody's happy. Otherwise, um, if we can, yeah. So it depends on you. Do you want me to round off, or I'm trying to make it short, 5 minutes, 3 minutes, but I'm also
Yeah,
happy to round off.
yeah, I think if we keep it brief, that would be great. Yeah,
Yeah, and if there are no other volunteers, then I just go to the concluding slides. Yeah, but I'm
sure.
happy to keep it very brief. So 3 minutes, candidates, I'm sorry. You just tell me the positive findings and then I will stop you, and I'm timing myself now, so it's a bit easier for me. I'll give 30 seconds for a volunteer to show up, otherwise we move on, Jelani.
Yeah, have we got a final volunteer just for a very, very quick one?
Mm-hmm. We'll be happy to volunteer, yes. Come on board. Is that Fintan again? Jelani, what do you think about Fintan?
I think that's a great idea.
Okay, if you say so, I guess I have no choice. Yeah, come on board. Yeah.
Thanks, Tony.
Okay, go for it. Yeah, go for it. Now, I'm really going to give you like very, very ultra short time, ultra short. So you better know what you're doing. Go for it.
Okay,
Start.
so inspect around the room, look for anything obvious, walking aids, etc. Next, inspect the patient. Any sign of
That's what
muscle?
you find on inspection.
I see. So he's got high arches and distal wasting, and sort of a
Yeah.
inverted champagne glass. So I'd ask him to walk
Mhm.
next.
Okay. That is him walking. Okay. Yep.
So he's got a high stepping gait and he's broad-based.
Mm-hmm.
Um, so my next step would be I'd ask him to do the Romberg's test, so feet together, hands by his side.
Romberg is positive.
Okay, so we would have sensory ataxia. Um, so and I see some form of foot splint at the
Mm-hmm.
bedside, so suggesting that there's distal weakness.
All right. So I am nothing else to see. So tell me, present your case.
So, young patient with distal weakness and sensory ataxia. So, I would think this is in keeping with Charcot-Marie tooth. In addition to that, he's got high arches, which would suggest a chronic neurological condition. And the fact that he's young would suggest that it's hereditary. Um, Differentials for sensory ataxia with weakness would include a lesion that, so I would think maybe some other form of peripheral neuropathy. So this could be alcohol, diabetes, something like sarcoid might cause it, or B12 and folate deficiency. Um,
So how would you manage?
so MDT approach, involving neurology and physio and OT and genetic testing. Also, you know, you'd have to consider driving in a patient like this if he can't feel his feet. You'd have to advise him to
Okay.
tell the
What are
DVLA.
the causes of peace cavus?
So there's Charcot-Marie tooth, also other issues affecting the lower motor neurons. So anything chronic. So I think if you had CIDP, that might cause it. Um, if you had an injury to the nerves, say a nerve root lesion at the lower spinal cord or an injury to the
Okay,
nerves.
okay. Well,
Right.
yeah, well done. So we're yeah, so the that's the reason I put this up. Causes of peace cavus, okay? If you ask about cause of anything, always remember structure, okay? Saves you time and it helps your memory, okay? So peace cavus, you can it's okay, hereditary causes like Charcot-Marie tooth, okay, Friedreich ataxia, or congenital talipes equinovirus deformity, which can also affect the foot as well. Okay. Or this could also be caused by metabolic conditions like diabetes. Okay, diabetes patient can have that. Thyroid disease, thyroid acropathy, very advanced thyroid disease. And then you can also break this down. This for other causes will include trauma. Okay,
Mhm.
trauma. Patient have had trauma, has surgery, yeah, injuries, soldiers who get their legs blown up and destroy their cars, step on landmines and stuff like that. So always structure, structure, and structure. Thank you very much, Dr. Um Finton. You're probably the star today. Every one of you were the stars. So I guess we'll round off, but if anybody wants to, so this is a stroke, okay? Patient with a stroke. What sort of gait is that? Can anybody speak up?
Antalgic?
Hemiplegic gait, yeah. Okay, so differential diagnosis of spastic hemiparesis, ischemic stroke, hematoma, tumor, abscess collection, demyelination, cervical myelopathy. It's a familiar face, isn't it? Is there anybody that doesn't know who this is? No? So examine this patient and what's the diagnosis? What's the diagnosis?
Parkinson's disease. Parkinson.
Parkinsonism. Yeah, it's always safer to say Parkinsonism because if there are other signs, if the patient have got vertical gaze palsy, you may be dealing with a Parkinsonism rather than Parkinson disease, or the patient have got profound memory problems and visual hallucinations, maybe dealing with dementia with Lewy body, or patient have got profound autonomic dysfunction and erectile dysfunction as well, we're thinking of MSA, um, or other causes. Patient is a boxer, like the guy that was shown, dementia pugilistica, which is from contact repeated blows. Or the patient had a stroke in the basal ganglia, and coming with Parkinsonian features, could be vascular Parkinsonism. And usually that starts from the leg. They have tremor, Parkinsonian signs in the leg, or indeed drug-induced Parkinsonism in patient taking antipsychotics. Now, I don't think we have time. I wanted to do one neurologic consultation case. If your exams are still far away, we may be able to take the clinical consultation that are neurology based. Okay, so we'll leave that for another session. But just to finish, yeah, there are two of them there. Would have, I think there's no time. So let's just do a little bit of slideshow, okay? So who can tell me what's going on here? Can anybody have a go?
Right,
We'll
I know.
finish. Right. I know. Why did you say it's right? I know.
Right cannot adduct and left is nystagmusing.
Good, good. That's correct. So, failure of abduction, that should be abduction of ipsilateral eye, adductive Sorry, that's that should be an adductive nystagmus. Oh, no, sorry, it's correct. Failure of adduction of ipsilateral eye and abductive nystagmus on the contralateral eye. Yeah, that's correct. It's due to a lesion in the medial longitudinal fasciculus. If you were in the first lecture, you probably understand this. So causes could be vascular or immune, inflammatory, tumors, etc. Okay. So have a look at this slide. So this is a gentleman, he's walking. That's look at the speed of vision. Is what can you see? Yeah, what can we see? Who can tell me what's that?
Left homonymous hemianopia.
Homonymous hemianopia, that's correct, okay? So these are so you need to know how to do visual field assessment. Yeah, so you need to know, typically in the exam, homonymous hemianopia is common. Bitemporal hemianopia is also common for pituitary or suprasellar lesions as well. So be very mindful. And what does what does this represent? Differentials?
Retinitis pigmentosa.
Absolutely. See those prickles, they're pigments, okay? Associations of retinitis pigmentosa are as follows. Yeah, that'll be there. Repsum, Kerenceas patients, they probably have seizures. They come with seizures as a mitochondrial disorder, so common in males. Usually, patients with retinitis pigmentosa have tunnel vision, so when you do the visual field, you see there's a circle area they can't see clearly. Glaucoma is a very close differential, but the discriminatory factors is from the history. Yeah, anybody want to have a go? Just say what this is and give two differentials. Excuse me.
Bilateral ptosis.
Bilateral ptosis it is. And 2 or 3 differentials?
So it could be myotonic dystrophy or
But would you mention myotonic dystrophy first, looking at this patient? I agree, but would that be your first diagnosis? Because in myotonic dystrophy, there are other things you will see around the hair.
yeah, i.e. that he's got full head of hair, so less likely without the frontal balding.
Yeah, so there's no frontal balding here, so I wouldn't mention myotonic dystrophy first.
Maybe
Just
myasthenia
saying.
gravis.
Myasthenia will do. Yeah, I will take that. Next.
Lambert-Eaton myasthenic.
Lambert-Eaton, yeah, that I will take. Yeah, next.
Bilateral Horner's.
That's Horner's is not a disease, it's a sign.
Mm-hmm.
You're nearly there. Sarcoidosis, okay? Neurosarcoidosis, a differential. Thyroid ophthalmopathy, metabolic conditions here is also differential. That's what they call CPO, chronic external ophthalmoplegia. It's a congenital condition, but yeah, it's a possibility. So neurosarcoidosis, bilateral ptosis, Miller-Fisher syndrome can also present like this, okay?
Cheers.
Ocular myasthenia, so they present with binocular diplopia. Usually you test with my single fiber EMG and all that. Treatment is as follows. So that's the end. Yeah, been a day. Thank you for your patience. Yeah, the time is not always our friend. And with neurology, more so with neurology, because if you really want to go to town with neurology, you need to be a bit more detailed. There are a lot we didn't do. Hopefully, when we see you in the physical course, we can, ask questions, demonstrate more, especially those physical signs. How you hold your patellar hammer, how you do your vibration sense, and how you also, um, you know, complete other examinations neurologically. So, any questions at all to the team? Jelani is still here. Any administrative question, any non-clinical questions for those who want to sign up for things?
I
Yeah,
think
you're welcome.
that's
Welcome.
everything,
Yeah.
Sonny.